suppressed or has malnutrition, they fare poorly. If the patient has been on steroid use, again, the healing might be delayed. You need to counsel these patients and avoid tourniquet times in these patients, specifically patients who have got vascular insufficiency, or, if you see calcified vessels on an X-ray of the knee. So, it's better not to use tourniquet in these patients, or if you are using, maybe use it for only the period that you're doing cementing, right? Then comes obesity, which is a big problem, which is catching up here also. So maybe, if the patient has a BMI of more than 40, I think Manoj has a lot of a lot of experience with these patients, but you need to counsel them regarding the results and maybe consider bariatric surgery in them. However, now, you have there's mixed data which is coming up, really, whether the patients who have had bariatric surgery, how they fare after knee replacement. Also, so metal allergy is another thing. So what I do is, mainly you can ask them, whether they have allergy to artificial jewelry. Now you have, allergy solution with all the companies, the gold implants, and it's not very expensive. So, a simple tip is to ask them, if they have any allergy to metal, artificial jewelry specifically, because that has got nickel. If they have, and then it's better to use the newer, tiobium coated implants or gold implants in these patients, right? So again, in literature, it has been seen that patients who have had allergies, whether it is metal allergy or any other type of allergy, they fare poorly as compared to patients who do not have allergy, right? And then always get full length X-ray. So this was our patient only, we never got this was long time back, maybe 15 years back. So, and the patient had a stress fracture below, which we could not pick up. So, always get long leg X-rays. And if there's a stress fracture, especially in Indian patients who have been walking on, or a very deformed knee, so often you might be surprised to have a stress fracture and they might require a stem. Okay. Then osteoporosis is another thing here. CR implants are very forgiving if you're using a CR implant. So at least, that takes care of it. On the tibia side, you might use a short stubby stem, but on the female side, I would strongly advise in Indian small patients who are osteoporotic to use, try to use CR implants and maybe use a UC insert in these patients, because, this was another patient who came to us, a PS was done outside and had bilateral, fractures within a couple of weeks from surgery. So it had to be revised. Okay. Another is the range of motion. Always counsel these patients that, if they ask SIF to start with, they would have poor range of motion, as preoperative range of motion is a good predictor of post-op range of motion. So smoking, although, most of our female patients are not smokers, but, try to counsel them to stop smoking. Is a difficult thing for patients, but even the anesthetists are very, fussy about it. They would not take a patient if the patient says that he has smoked in the last 2-3 days also. So, but smoking again has been correlated with the adverse outcome. CVA again, and most important is patients should know what they are expecting from the operation and should be the reality. So, you should not tell them that they would have no pain or none, so they would not require any sort of physiotherapy, or they would be walking the next day as they were maybe 10 years back. So, their expectations and reality has to be matched, because if they have unrealistic expectations, that really impacts their, satisfaction post-operatively. And all these comorbidities such as diabetes, specifically hypertension, hypothyroidism, needs to be controlled before the patient is taken surgery. And the question of simultaneous bilateral controversial topic. The bilateral TK is beneficial for patients who are fit for it, but if the patient has got any, any contraindication for it, basically if they are elderly, more than 70 or 75 years, and have an active or pulmonary. So these are all, these have been described in literature where you should avoid a bilateral total knee replacement. However, Indian scenario is a little difficult. Sometimes you have patients with severe deformities, and doing just one knee at a time might not be these patients. You need to maybe use technologies such as, patient-specific jigs or navigation, or maybe a robot. So, maybe these patients who require a bilateral and have some contraindications. So, here there's no embolism or no, I think you should take help from these technologies and do this. And the other is the psychological and behavioral factors. So this, we did a study and we found that in Indian patients also, We had around more than 100 patients, and we used the HADS and the PCS. This HADS is a hospital anxiety depression score, and PCS is the patient, catastrophizing score, and TSK is the temper score for kinesiophobia. So we use these scores and preoperatively and saw how is their outcome. And we also have published this in IGO later on. And what we found that around maybe 104 patients, we had around 8.6 patients who had a previously undiagnosed psychopathology. So they had some depression and anxiety, and these patients fared poorly compared to the other patients. And we also found that the degree of anxiety correlated with worse knee pain and stiffness up to 6 months, and the degree of depression, pain, catastrophizing was also correlated with worse knee pain. So, if patient is complaining of pain which is out of proportion to arthritis and is very anxious or has symptoms of depression, or you feel like that, so maybe there are scores which are there in literature. You can use those and maybe, refer them for a psychological counseling before surgery. So, and this was our paper from India, but there are studies which is a well-established fact that mental health and has a relationship with outcomes after a primary total knee joint. In order to pick winners for total knee replacement, first foremost we should know that spine, right, and have a full control of comorbidities, consider their psychological as well as mental status. Set appropriate expectations, and for that you require a good patient counseling and plan the operation well. And I think, and also do the operation well. I think Manoj and Shekhar are going to demonstrate the same in their life surgery. I thank you for your.
Okay. Fall one, I think a very common thing. Whenever we have cases with those venous insufficiency and you have this kind of bluish discharge, where is the, because literature, we all talk about tourniquets, right? With or without tourniquet, but there's no cutoff. What is your viewpoint personally? Would you take these patients in for a single stage bilateral, or you would?
No, I would maybe do a staged one, means do one at a time, so that I'm sure that the skin is holding on.
Which is very important.
And the other thing is that I did not mention, more than that, you should see the ABPI, ankle, and the break, index. That is more important rather than everything else. So that really tells you if there is any vascular insufficiency or not.
That would tell you in cases where you see calcification.
Yeah, where there is a calcification.
Venous insufficiency.
Yeah, venous insufficiency is maybe one at a time, and maybe as you take into confidence a vascular surgeon also along with you, and maybe have a consultation from them. Yeah, and in these patients, I think preoperative Doppler is a good thing to do for venous insufficiency.
I think summary points is the preoperative Doppler, consultation with a vascular guy to cover you up medico-legally. On a safer side, go one by one and try to do these surgeries without a tourniquet. I think these are very important messages.
And maybe use DVT prophylaxis in these patients specifically.
So what is your take on in a unilateral doing at a one knee or a bilateral knee? If a patient is diabetic, so what is your take on doing? You can do a one stage bilateral or
I think if the HbA1c is less than 8, you can do bilateral. If the sugars are controlled, it should not be uncontrolled.
And if you do one knee, what is the time interval you advise to do the second knee?
See, ideally it should be 6 weeks, but I think you should wait at least a week. Means there's very few literature. There's a study by Meryl Ritter. There are 2 or 3 studies only. In literature is nothing like that. But you should not do it within a week. That is we always postpone it for a week, because the phenomena of the second hit, or the prothrombotic phenomena is maximum at 3 to 5 days. So doing it after 7 days is fine. But ideally speaking, you should wait for 6 weeks.
Means, do you have any studies or thing which on nutritional basis you decided to do it a unilateral or a bilateral?
No, I don't think for nutrition basis, but overall it is seen that, if your albumin level is less than 3, so it's better to, build it up, and not giving IV albumin. That doesn't build it up. It's dietary, that way around.
Thank you, sir.
Well, I'll ask one. So most often I find some people come with severe osteoarthritis, they don't have any pain.
Yeah.
Okay. But some having very grade 1 to maybe grade 2, grade 3 osteoarthritis, having severe pain and pestering you, I'll go for a knee replacement. And those severe ones, they don't, even if you tell them you need a knee replacement, they say, I'm fine. So how to select this type of
Yeah,
patients?
so so that's a very good question. So maybe in a year, I have 2 or 3 patients who come with who have a significant amount of arthritis. If you just show the X-ray, you will say that it requires a knee replacement. But the patients are functionally fine, means they don't have any pain. All right. So means for me, unless it's a deformity, some of them are quite deformed. If they're doing it for deformity, maybe that may be one thing that you might do it. But I don't do a patient if he doesn't have pain. So, I would stay away from it. It might be a neuropathic sort of joint, or it might be some nerve compression somewhere. But if the patient doesn't have significant amount of pain, I normally stay away from doing a knee replacement. Right. As far as the second question is concerned on grade 1 or grade 2 patients, so, the pain threshold for patients are different for different patients. So sometimes some patients who have, but if they have, then you need to see the X-rays. You need to do, the modified Rosenberg view. Sometimes the X-rays are very fallacious. So, they might be having bone-on-bone arthritis, especially on the medial side. And sometimes it's the petrofemoral pain also, which is, patient tibiofemoral joint is not that bad, but the petrofemoral pain joint is very bad. So sometimes you have these type of patients also. So look into that, get a skyline view done, get a lateral view done. So, that way around.
Thank you.
Thank you.
Now I invite our next speaker, Professor Ratanu Mahanti. He'll be talking on the challenges of doing TKR in a less systematic setup. That means in the setups which are not well stocked up, maybe the staffs are less efficient and maybe the inventory is very less. So you have to adjust in between that. Professor Mahanti.
Good afternoon, everybody. I will be speaking on an out-of-box subject, the challenges of doing total knee replacement in a less systemic setup. And those setups are now more and more available, and more cases are now been done in those type of setup. So number of total knee replacement which was done in 2012 in India was around 80,000, which is expected to grow to millions by 2030. However, being an elective surgery, the patient never accepts any mortality, morbidity, or any complications. However, the 30 days mortality is near about 0.25, that is 1 in 400, and 1% have got the risk of post-operative infection even in the best setup. So many government institutions, including medical colleges, have not been able to do knee replacement till date because of fear of failure or actually having a failure. And the new medical colleges which are coming up, they are mainly the hospital is attached to the district headquarter hospital, but the setup is still bad. And this have led to a few abortive attempts, or surgeons who have started doing them stopped it in the hope of getting a better OT setup, which usually remain a mirage. With the Ayushman Bharat scheme coming into play on September 23rd, 2013, covering more than 60 to 70% of Indian population, providing 5 lakhs per annum per family and around rupees 1 lakh per single total knee replacement, we are bound to see more and more such replacement cases being done in less systemic setup. And this is inevitable, and this is going to happen invariably. So, but what we get in those setup, we get usually compromised setup, compromised patient, compromised team, and also compromised resource. And these all 4 compromised things usually leads to failure. So, but you cannot avoid it. This has to be done for the poor patient of the state and for the training of the juniors and residents. Those are very essential thing, because those training of the juniors and residents, they actually comes from the medical colleges, where the setup is usually not that good. So the hurdles that we usually used to face is to good OT setup, a good team setup, compromised patient, financial constraint of the patient, instrumentation, constraint of the instrumentation, and the problems of the post-operative management. So how we overcome them? See, on one side, we get an ideal OT setup, but when we get such a OT setup and we aspire to do a knee replacement, it is a nightmare. But the previous in this such as government setup, there is daily OT, and by the time the other fellow leaves the OT, he leaves the OT in this condition. And so, if you aspire to do this, it is a nightmare. Knee replacement, this type of OT, it is a nightmare. So let us find out the hurdles and what may be the solution. So maintaining the cleanliness and sterility of the OT, this can be solved by a thorough vigilance. If you are going to do a replacement next day, be sure that your OT is clean and sterility is maintained, because usually the sisters, they are not bothered, they are not so much serious about this thing, and you have to be more extra careful in that. Then restriction of the mobility. This can be done by sensitizing the staff. So when we started, we had put one notice in on the OT door, total knee replacement is going on, and think before you step in, and if you have entered, the exit will be restricted. This is just to sensitize the patient. And moreover, if you in some old medical colleges, you find that two tables are functioning simultaneously. So in that condition, what you have to do, you have to run a single table and stop running the second table when you are doing a replacement surgery. So modification of the OT setup was done by to get the OT key yourself before the night of surgery and keep it with you. Do fumigation overnight. You have got 2 tables, operate on 1 table away from the door, and limit the door opening to the minimum, and see that there are less person in the OT. If you do 2 things, that you limit the door opening to the minimum, and you have less person in the OT, what I personally feel, you can solve a lot of problems. Then coming to the team setup, in a government hospital, when you are starting such cases, your team there's a repeated change of teams. So what I feel that at least 2 members of this team should remain constant. So the team should be dedicated and motivated. And when you are starting new cases, to do it initially, repeated practice and instrumentation with synchronization of the steps of surgeries are required, so that you can minimize your time. Trust and good communication between the team members must be there. As it is told, a successful team had beat as a one beat. Then compromise of the patient, you may find that, because in government setup, what you find, a severely compromised, severe deformity patient will come, and you have to think about some innovative practical solution where you cannot get so for example, a wedge, a stem extender. So you have to think some other way how to overcome them. Then you will get patients who have got severe comorbid factor like diabetes, hypertension, immunocompromised state, anemia, etc. So this can be solved by maximum optimizing the patient. So this is a case of severe deformity, and we dealt in this way, just shift and resection technique. This is a severe deformity in a compromised patient, both knee, both hip, do it one at a time, all 4 in 4 sitting. I think there's some photograph there. There may be certain financial constraint like insufficient fund and long waiting period. Long waiting period cannot be managed as such in a government setup, but funds insufficiency can manage by central and state government insurance scheme. then when you are going to start such surgery in a government setup, you'll find that some basic instrument like intelligent tourniquet, fine instrument, bipolar cautery, pulse levels, etc., methylene blue markers may not be available at the time of need. So you have to make a basic list of the basic instrument appropriately, and you should supervise these things personally. Then again, there may be certain hurdles in the post-operative management, because you may not get an ICU or STU when you need it. So what we used to do is that we do a overnight, we arrange the pulse oximetry, and overnight we manage with that. And also we put a urometer so that urinary intake output, this can be managed. And it is usually better to avoid a bilateral knee replacement with patients with chronic heart disease, chronic kidney disease, if you don't have a good ICU monitoring. And for another hurdle is that you detect any initiation of the infection. So that you have to do a bedside chatting, like parameters like pulse, BP, temperature, etc. And CBC urine analysis are to be done either once in 2 days. Post physiotherapy, you have to do it yourself, and so that a person experienced in knee replacement physiotherapy must be involved in the system. So the aim is to aspire, act, and achieve. That is key to success. Thank you.
Thank you, Professor Mahanti. Any questions? I'll just ask one thing, highlight. You told in a government setup, when these companies, they give the equipments, they don't give good quality of equipments also. In private, I'm telling you, in private setup, they give good equipments, but when they come to government setup, where you are, they don't give good equipments, all old ones. When we put a hammer, it broke. I have seen 2-3 tibial guides, jigs, it broke, I have seen. And even this company, once they gave, after I checked everything, I found that perfect fit was size 3 tibia tray, but they have only size 2 and size 4. And because it was, they told it's not possible because short supply, nothing is available. You have to adjust that. Then how to adjust in those situations?
See, that you keep the company people on toes only. We scold
They
them.
told will provide everything, but on the table, see, this is the fact. They
So
told
if
we
you,
don't have any
if you
stock.
keep them on toes, then only they will be afraid. Or you stop their payment.
Yes.
See, if they become callous, that is the whole problem. They think.
Sir, that is a good topic, sir. I have also operated many cases in less systematic setups. The only thing which I am aware of is that I should use a lot of disposable drapes, disposable things. And most important, taking care of the pre-operative scrubbing is very important. Giving IV antibiotics at least 1 hour before the surgery. Even if it's a less systematic setup, if we can take care personally, that giving the antibiotic pre-operatively and taking care of the surgical site, proper scrubbing of the area, and using disposable drapes, gowns, even in a bad setup also. I think...
Yes, now these things have been done in less systemic setup. This is inevitable. This will happen. Because of this insurance scheme, these things will happen. But thank you.
Thank you, Dr. Mahanti. I think that point is taken well care of, that one should keep the key of the OT previous night, and hopefully don't run away from that, because the next day the theaters will be cancelled. May I now request Professor Dr. Tanmay Mahanti, who's going to speak on the operative room setup in TKR. Dr. Mahanti, please.
So everybody is happy because they know what is my topic. So the moment you look at the topic, you'll see already it has been discussed. So how to set up an OT for TKR? Most of the surgeons standing here or sitting here are good surgeons. They know what is a good OT setup. I see my postgraduates. I'm happy that they came to listen to people. 1 or 2 messages they take from here is enough to save some of the needs in future. Sometimes I feel sorry when the young generation does not listen to whatever we are planning. Transferring. এটির অপেক্ষা না করবো। হ্যাঁ মোবাইল শেষ একটু দেবেন। হ্যাঁ ঠিক আছে। হ্যালো, থ্যাংক ইউ। So basically my topic is operative rooms setup for TKR. The moment we discuss about it, first thing it comes, already it has been discussed. And once we are thinking that we are planning for this surgery, obviously we aim something. Any surgeon will look at this, will think that I must look at the alignment and stability of the knee. At that moment, only one thing which puts us in problem, that in future we should not have infection. That is why the moment we think about a OT, we always think, can we not avoid infection? And what Professor Mohanty already told, when you are going into a OT, maybe your friend has started a nursing home and he is asking you to do a knee replacement there. You go and see first the OT and then see whether you will do a knee replacement there or not. Beware, it is not a hip. In a hip, the tissues are covering the hip like anything. In TKR, it is very easy. A little bit of infection, next day you can see it. It becomes very superficial, and within 2 or 3 days, you can know the flare of the infection very fast. And when you look at it, the first thing you have to consider about the sterilization. So there are times when we depend on the people who get it sterilized from outside, never believe them. And second thing, suppose you are doing a sterilization by autoclaving or anything. How many hours have passed after your sterilization? Please check it in your hospital. It has been seen yesterday, somebody was going to do a surgery. The things have been sterilized. For some reason, they have cancelled this surgery. And today you are going to do this surgery. The same set is coming to you in a sterile form. You think that, yes, it is sterile. But how many hours have passed? You know, each hour it has passed, the chances of sterility is less. So these are the conditions if we look at it. The moment we talk about the dripping, already, as Dr. Patnaik told, that when he gets into a OT somewhere outside his Apollo hospital, he looks at the same thing about the dripping. And when you look at the dripping, you try to use as much as possible the available drippings which are disposable, so that at least you are damn sure the layer in front of you is 100% sterile. And instrument sterilization, already I told you, and the implants already, most of them are already pre-sterile. When you look at the drips, now these are available to you. You need not bother, because for each set, you have to get these things. Never bother that you will manage in a nursing home setup and then go on with that. Hoods, yes, available nowadays, and you can just cover it. But without that also, people are doing these surgeries. And when we look at it, what the operating setup should be like this. I'm operating in this OT, where the laminar flow is there. The surgeons are with hoods, everything. Yes, I understand. And the moment we look at the principles, we consider it to be supraseptic operating rooms. What do you mean, supraseptic? So you have a faith that in this OT, possibly you will not have infection at all. Then only you will be confident to do these surgeries. Try to keep minimum instruments inside the room, and also try to avoid limited numbers of people inside the OT, and always look where the air suction is going out. So even if you are opening the doors, you know the air will go out through the doors. But when you are closing the doors, more people come in, your OT becomes affected more. Simple thing for a knee, you can keep the knee straight, and you can drape it properly, and put a tourniquet when you decide, and then you position the patient and operate. All these things when you are doing, there is a lot of possibility. When we are putting the tourniquet or anything, whatever skin preparation you had done, maybe somehow become unsterile. You have to be careful about that. And when you put a tourniquet, somebody uses a smudge with that, everything. So you must have a smudge, even in a clear plant case, sterile smudge. And at that moment, you think whether you will use it or not, looking at your patient selection, you decide. Now, basic aim is to put the patient's positioning. That is, you keep the limb in this position, so that on lateral aspect, you put something like this, or then you look at the foot. Many surgeons are here who are not using this. or some of them use this. Whatever is the aim, finally you come out to see that the leg is kept like this. So you can keep nearly 90 degree or more than that flexed when you do the surgery. And after that, you can straighten it so that you can see the alignment of the limb anytime you want. So your basic aim is to put the heel in such a manner that you can change it. And we cannot call it a fashion. We can go into the internet and find a lot of things available like this. I have never seen this being used by any of these surgeons. I don't know why, but it is in the internet only. We see that in Mayo Hospital and other hospitals they are using. And I have also asked some surgeons who have worked there. They told sometimes I'm comfortable with what you are doing here without these type of things. The last one, if you look at it, I'm thinking of using it here, which can be also used for tibial interlocking nailing like this. Now people are making it made up of simple wood so that it can be utilized. And when you try to put it there in that position, it is easy to operate. I want to give message to younger generation, look at this. When you are using the operation table under a laminar airflow, what you see? The laminar airflow is throwing sterile air onto the patient and on you. And that goes away. And finally, it comes back being filtered. Now, suppose you can see the lamp under the laminar airflow. And by chance, there are some dust over that. And when the laminar airflow throws this, the dust will straight come to your patient. So you have to be over careful when you look at those things, because the HEPA filter may have cleaned everything, but the lamp there is a site from where you can get dust with bacteria. And sometimes this laminar airflow has proved to be more dangerous than conventional method. When we discussed about the instrument, Dr. Mahapatra told that sometimes we get bad instruments. General instruments is yours. The company people, they come with the special instrument, the standard instrument for TKR. Of course, as he told, sometimes they have been several times used, and sometimes if you are getting a defective instrument, you will face it on the table. Sometimes you have to keep the other things. Suppose while doing a surgery and you have got a pathological fracture, periprosthetic fracture, or something like that, at that moment you have to handle it. So always, even if you are doing a basic TKR, you have to keep your plates and other things ready. In case there is a pathological fracture, you can use it. So the basic instrument when you are keeping, I find one thing, that the simple oscillating saw blade. If the blade is new, the surgeon is comfortable. And sometimes even a little bit of old, which has been used several times, I see in good hands even you cannot get a stumper cut proper. That's why I'll suggest you that see your instrument, wash them properly, plan it, and when you look at the implant, do not compromise. Do not think that I can come out with this type of implants. Even one surgeon told me, this patient is coming for the next knee. The previous knee had this type of implants. Possibly I'll be putting it there. I need not bother about the other things. But on the day of surgery, there is a possibility you may not get the right side of implants. You must check with the sterile implant whether it is available there or not. And sometimes while operating, you may miss that one of the instruments may fall down from your hand. You must have sterility methods by which you can do a very rapid sterilization in your OT. Now, robotic surgery today, we are discussing about it. More instruments coming in, more chance of infection. These transparent drapes sometimes help you, but you have to be extra careful to see that there will be no breakage in sterility when you do this type of surgery. Just I want to give one message. In 2016, a paper came out from some Indians, that is Singh, Reddy and Srivastav. They came out, wanted to know the effect of laminar airflow in the OT. And they wanted to get the data from the National Joint Registry to know the local surgical site infection after being operated in a laminar airflow and non-laminar airflow. And luckily, they could get some data from England, Wales, and North Ireland. And from there, they got that a hospital had two hospitals, one where they were having laminar airflow, the other hospital did not have. From the same surgeon, same people they were working, they could get the data. What the finding was, the revision TKR was 16 out of 2,234. And when you look at without laminar airflow, it was 3,694, only 19 cases. So what is the difference? Difference is very less. And when it comes to THR, you find that 5 cases out of 1,752 were infected or revised, and 12 cases out of 3163, that is 3,160, only 12 cases. So from that they found that the p-value, whatever they saw, and found that not much difference. That means laminar airflow doesn't have that effect if you are taking proper sterility. And whatever we discussed, that we should see that the sterility is not broken and proper sterility is done. And then our OT is a conventional OT. It can be operated like this, may or may not be with laminar airflow. If your method or your protocol prevents infection, you can do good result with that. Thank you.
Thank you, Dr. Tanmay Mohanty. Any questions, please? And if there are no questions, may I request Dr. Kishore Panda to please speak on surgical approaches in primary TKR. Dr. Kishore Panda.
Good afternoon, chairpersons, and I'd like to thank Sanjeev sir for giving the opportunity. So my topic is approaches on TKR. So after completing these all those basic things, now we will enter into the TKR proper. So my topic is approaches to the TKR. Though we know many of the approaches, to me there are two basic approaches. One is medial approach and another is the lateral approach. Basically, the medial approach is divided again into the others subcategories like mid-vastus and sub-vastus approach, and these are mainly categorically named after the method of arthrotomy. So before going to this approach, why a TKR fail, and many of the literature suggests that it is traced back to its original anatomy. In valgus knee, the knee is varroid, most of the cord is varroid, and in valgus knee, the lateral release is not adequate. That's why they fail. So that's why the knee open and it's like just like a book. So before going to the approach, just see the patients clinically before night. So you have to, the video is not working. Okay. So you have to just clinically check before the night whether the valgus is correctable or not correctable, whether the varus is fixed, whether there is any laxity or not. So for a happy TKR, these four things to be balanced, that is soft tissue balance, gap balancing, proper bone resection. But this gap balancing is based on the two. I don't think any TKR which can be corrected either only by bone resection or by soft tissue resection. You have to combine both these together to get a proper happy TKR with a proper rehab. So this is in short, this superior genicular artery and supreme genicular artery, these have some surgical significance. And for any TKR to approach, the skin to be erased just like a flap, as thick as possible. Standard medial parapatellar arthrotomy, the supreme genicular, medial, superior, and inferior genicular arteries are sacrificed. Lateral meniscectomy, the lateral inferior genicular is sacrificed, and try to preserve the lateral superior genicular artery if the lateral release is needed. These are the three important vasculature which need to be kept in mind always. So which approach is ideal? That is easy to learn. The approach must be reproducible, lesser soft tissue damage, good visibility and accessibility for the anatomical landmark, facilitate rehab and extensile whenever it is required, and easy closure with near anatomical restoration. So most of the surgeons, they use this 95% of the time, that is medial parapatellar approach. Why it is? Because it satisfies all those previous characters, and it is excellent. It gives an excellent exposure. Even into the lateral aspect, it goes, most of the structures are visualized. So this is the skin incision, just medial to the, starting from the suprapatellar area, just medial to the tibial tuberosity. And this is the arthrotomy. Though the incision is straight, the arthrotomy is just like this. It is carved at the proximal pole of the patella, then somehow straight up to the 5 mm medial to the tibial tuberosity. Scott himself has written in this
the medial parapatellar approach can be used in virtually every cases, regardless of the preoperative deformity and range of motion. So three essential structures need to be identified. That is the proximal medial border of the quadriceps tendon, a point halfway between the vastus medialis insertions and the superior medial pole of the patella and the medial border of the tubercle. If these things are palpable, then you can perform TKR by medial arthrotomy or medial parapatellar approach in any cases. So step by step, incision stay medial to tubercle, 5 mm of quadriceps is left attached to the vastus medialis obliquus. Yeah, incise the anterior horn of the medial and lateral meniscus, but don't jump into the resection of the meniscus. Medial tissue release, develop a soft periosteal medial sleeve, and from anterior to posterior, you have to release it. The idea is before cutting any bone, you just correct the varus as much as possible and make it gain the mechanical alignment before cutting any bone. So without cutting this lateral patellofemoral ligament, the arthrotomy is incomplete and it is very difficult to evert the patella. And just put cautery mark on the proximal pole of the quadriceps tendon when it will be easy when you are opposing or closing the TK. So this is one thing, and you have to pass. Once you cut the done the arthrotomy and everting the patella, then you have to put a sleeve or a curve osteotomy just below 5 mm below the chondral margin from anterior to posterior. Along that, you release the superficial, the deep MCL and other posterior medial tissue, so that without releasing the posterior medial tissue, it is very difficult to correct the varus. So once you identify this, try to locate your PCL. Sometimes it is osteophyzed and you have to release it with the osteotomy. So before bony cuts, try to correct this thing I have repeated and gain the mechanical alignment. So there is a trick to resect these lateral meniscus. Many of the authors suggest that you try from the posterior horn, come to the anterior horn, and don't touch the medial part, because the medial part is very close to the lateral genicular artery and there is every chance to sacrifice it. So before cutting the lateral meniscus, you can put a small hole for the putting the Homan retractor for the tibial cut. Then again, after cutting the proximal cut and distal femoral cut, you can do the meniscectomy. So there is a set of amount of quadriceps tendon that is divided proximally depending upon the need of extension of the exposure. And 3 to 5 mm of quadriceps tendon is left attached to vastus medialis obliquus for the repair. In most of the varus, this distal amount of medial tissue just attached to the periosteum near the tibial tuberosity. So disadvantage is medial capsular repair, development of lateral patellar subluxation if the repair is not good. Access to the lateral reticulum is less direct and may jeopardize the patellar circulation if lateral release is performed. So coming to the lateral parapatellar approach, the main indication is the valgus knee with a subluxation of the patella or patella maltracking before TKR and tibiofemoral angle is more than 10 degrees. So lateral parapatellar is not just the reverse of medial parapatellar approach. Many of the series they have shown that the eversion of the patella is difficult. One of the largest it is 149 valgus knee. They have not able to reverse any of the patella. So what they do, they after the skin incision, they release the lateral tissue. They erase the IT went from the up to the gradis tubercle up to the head of the fibula, and then they cut the proximal tibia, then they cut the distal tibia, then they cut the patella surface. Then only it is able to mobilize the patella and they get the access. So this is as we get the soft tissue below the patella, it is not like in the lateral parapatellar. It's full up with the fat. So try to preserve that fat. If you release the meniscus early, you will lose the fat. So this fat
अपना वाला इसमें चले जाएगा
of the lower pole of the
compatible है वाइजर
fat
नहीं इसके साथ compatible है
some amount of gap may persist.
अभी कह रहा हूँ
So this is how used for the closing of the arthrotomy. Then mid-vastus approach, it is again a modification of the medial parapatellar approach. The incision, this arthrotomy is midway between the vastus medialis muscles and it is little bit oblique above the superior genicular, supreme genicular artery. So the vessels is not disturbed, but the advantage is we can lose some amount of motor innervation to the muscles, and everting the patella becomes difficult, though many suggest that the quadriceps strength, rehab is good and SLR is good, but these are only very short term. At the end of 6 months, these may be good, but at the end of 2 years, everything is equal. That is medial parapatellar and mid vastus.
Sound check kar raha ho puri?
All are equal. Subvastus is just below the
Straight rakhna, seedha
vastus
rakhna.
ventralis muscles, and
ऐसे.
same thing, same advantages, same complications
Yes.
corroborated here.
एक कुड़ी मैंने बटाला की कुड़ी ने दसे जरा.
Advantage
ये कर रहे हैं ना. चल
excellent.
देखो हिंदी बताता हूँ. इतने को पता बटाला है अमृतसर के आगे.
The diagrammatic
ऑपरेट
representation
करने
of
गया
subvastus.
हुआ था. तो मेरा लड़का ना उस वहां पे क्या होता था, वो बीकर के टाइम ऐसी होती थी. वो उसको टेढ़ा करके इतना डाल रहा था. वो डरे नहीं, घबराए जाए.
Extensile
छोटी
approach
सी साइड पे है कि भैया छोड़ो, मैं बताती हूँ कैसे डालते.
quadriceps procedure, you have to obliquely
तो ये कर रहा था, मैं तो भी हंस रहा था.
on the margin of quadriceps tendon.
छोटी सी लड़की थी, 5 फुट की.
You have to evert the patella, and this is also like a VUI quadricepsoplasty. You
यार
have
एबी वाले को बुलाया, चेक कर ले भैया. कर बाइजर लगाने के बाद कुछ नहीं चेक होना.
to do the tibial tubercle osteotomy to make it extensile. These are all quadriceps nerve. This is
पटाखा
how
तो नहीं बोलेगा.
they have.
ये
There
भी
is a
चीज ऐसी है.
modified lateral.
सैटेलाइट टेलीकास्ट मैं तो बहुत कर रहा था ना पहले, मतलब
और
टेलीकास्ट
नहीं
इतना
आता
ज्यादा होता. ऐसे हुआ
What
सारा
that
कुछ बना के सैटेलाइट का हो गया. डॉक्टर भान की मीटिंग थी और मुझे उसमें 5 सर्जरी बैक टू बैक. उन्होंने मुझे कहा कि मनुज ये गोजी कौन थी. हाँ, गोनी की भी थे. मैंने कहा यार मैं दौड़ गए रात को, दारू पी थी. कहता बस शो भाई तू चला दे कल का ना. मैं कहा है, मैं कितने, कहता मुझे इतनी सर्जरी दिखाने हैं, 3 घंटे हैं तेरे पास.
now the concept of MIS in
तीनों टी पैरेलल चला दूं.
the exposure is
Leg
very
to move
for
कर ही
they are
सकता है,
what
but
they are
वो
doing. They are doing
क्या
two
चला दे.
window. One is suprapatellar
रोड सर्जरी के बाद उसकी बैटरी जो वैसे पूछ रहा था बार बार.
just
मैंने 3 घंटे बोल दिया.
exchanging in between the two window. So
मिडवे बड़ा मुश्किल हो जाता है.
sounds well. It has been found that the malposition of the components are more in the MIS.
नहीं अच्छा है यार तेरा बढ़िया. मेरे को ये नेक्स्ट मंथ ना पंजाब ऑर्थोपेडिक एसोसिएशन के लिए लाइव टेलीकास्ट करना है. पटियाला जाके करना है. यूट्यूब पे ऐसे है.
Go for a medial
बॉडी दे दूंगा
parapatellar.
भैया.
The valgus is fixed.
वहां जाके कोई कांड हो जाए. हाँ.
Deformity and
बड़ा गंदा है. तो मेरे को डॉक्टर हरिओम वगैरह है, तो उसका मुझे लाइव सर्जरी मुझे करना है. पीवे
go for a medial parapatellar.
पता पहले ही पीवे कौन का हाल क्या होता है.
The message don't overdrape the ankle and foot region.
तो
Make a proper mechanical alignment.
पहले ही उसका
Intervention
कॉम्प्रोमाइज
under anesthesia is important. Release the contracted side to achieve the anatomical alignment.
नहीं कर रहा हूँ ना. अगली बार कर रहा हूँ.
Distal femur cord depends on posterior contracture and patella eversion, fat resection, and these don't have a very promising. Some people advocate release the fat pad, some advocate don't release the fat pad, but these are only for short-term outcome. The long-term outcome are depend on the major resection and gap balancing. Thank you.
Very nice description of all the approaches. Now I ask any questions from the audience. नहीं. I invite our
Hello, hello. Hello, hello. Hello, 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 hello.
हेलो हेलो.
good. Now I invite Dr. Sujit Tripathi, one of our most bright star in field of arthroplasty, to present the most important topic, major resection versus gap balancing in TKR. Dr. Tripathi, please. Then we can continue after the surgery. Okay.
आपने मेरी कमांड्स को सुनना है बस, ठीक है? मैं कब ये साइड भी बोलूंगा और एक ही स्टेज पर टॉप भी बोलूंगा, तो टॉप भी ऊपर से लेके आना है। हाँ बस अभी इसी पोजीशन पे आप रहे। हाँ टूरनी के आप कर दीजिए, टूरनी के आप कर दीजिए। So are we audible?
No. Yeah, you are audible, but we cannot see the screen. Huh? OT.
Is the camera guy?
Hello. Hello.
So what we have is a typical bilateral varus deformity for which right knee has been done by Dr. Sandeep around 3 months back. Now what we have is the left side.
स्पॉटलाइट का हेलो
Show me a long shot view.
होटल सूर्यांश को स्पॉटलाइट कीजिए सॉरी
आप एक काम करिए, सुनिए कैमरा, आप इस साइड स्क्रीन को ले आइए। कैम
हेलो
नहीं लॉन्ग शॉट व्यू नहीं दिख पाएगा ना
अभी हुआ
Okay, okay, fine.
मुझे लॉन्ग शॉट व्यू चाहिए।
Paresh, please, you are invited to moderate the session also. I'll be there also.
सामने की तरफ से जाएंगे बेटर होगा।
Dr. Manoj,
Yeah,
are we audible to you?
yeah, I can hear you all.
Dr. Sanjeev and Dr. Paresh, we both are moderating this surgery.
Wonderful, I'm delighted. Huh? Okay, what I'm going to show you is a cruciate retaining CR knee. I was talking to Dr. Sandeep out here. I was trained by Chit Ranawat, so I am a hardcore PS trainee. So first 15,000 knees were only all PS knees, like any guy trained across there. But last around 10 years plus, double that volume has been only CR knees. So transition from a once you start getting accustomed to a cruciate retaining knee, you do not require PS in 99.5% of your cases. So this is a correctable varus deformity. If I go in a varus stress, I have around 30 degrees of varus. At the moment I give a valgus stress,
Manoj, we are not
normal.
seeing the
So
OT.
this means what is
Hello.
the cause of my deformity is not primarily the MCL, but it is basically the medial bone defect, medial and the posteromedial bone defect.
Hello.
So although I
Hello.
use all approaches,
Hello.
yeah, can you hear me?
Dr. Manoj, can you hear us?
Yeah, I can hear you. Can you guys hear me?
No, actually, we are not getting the OT. Yeah, now it's okay. Now it's okay. Yeah, please go ahead.
So this is where your knee lies. You have different approaches to move through. For the ease of the live telecast, I'll use the midline NCN and medial parapatellar approach. So my normal MI NCN is from the tip of tibial tuberosity to 1 finger breadth of the superior pole of the patella. That is my normal NCN. But out here, I'll keep it a bit longer. So that's my normal scar. I do not want to have any scar going on.
Manoj, can we see the X-ray, please? Can we see the X-ray? We have not seen the X-ray.
You have not seen the X-ray? एक बार आप X-ray दिखाइए उनको.
हाँ.
X-ray पे focus कर दीजिए.
Yeah.
So we are going to operate on the left side. As you see on the X-ray, there is a medial posteromedial bone defect. Lateral side looks very pristine. There is also involvement of the patellofemoral joint. Along with that, we have a loose body in the extensor apparatus in the suprapatellar pouch.
Yeah.
So in this case, what I have is a posterior slope roughly around 5 to 6 degrees. This is very important because
In a CR knee, we are supposed to reciprocate the native slope of the proximal tibia. So since it is interactive, Sanjeev, I would suggest any point, anytime you require, just keep stopping me.
Yeah.
So otherwise, I'm used to a 10-minute TKR. I might go very fast, so I'll go slow, making sure that we explain all the steps. So this is a very important part. This incision, you have to have a thick flap, dermal, subdermal layer, and identify the silver fascia.
Dr. Manoj, you have used the tourniquet, I presume?
Yeah, we have used the tourniquet.
Yeah.
So these days, it doesn't make any difference use because my tourniquet times from incision till implantation is less than 20 minutes now. So unless when somebody has a atherosclerosis, was explained in the beginning, those are the surgeries I do without a tourniquet, or high intense cardiac patients, or a Charlson morbidity index being very high where the ASA grade 3 or 4 is there. Those are the surgeries I do without a tourniquet. Need to put up the cat's paw. Hold this, the second one.
Manoj,
So you don't require extensive scars. Soft tissue dissection is extremely important. So when we are into this zone, out here, you have 3 approaches to move forward. If supposing I want to use a subvastus approach, the camera sab आप साइड को जी मुझे सामने दिखना चाहिए क्या देख रहा हूं मैं ठीक है हाँ जी
हाँ.
So if I start my incision from here and enter here and lift this VMO, I'm going to be into a subvastus zone. I come out here and start my incision going in these planes, it is a mid-vastus. And if I extend forward, maintaining 1 to 2 millimeters of the tendon, still a quad sparing, it's a medial parapatellar. So it's all modification of those approaches. You want to go subvastus, you want to go mid-vastus, or you want to go medial parapatellar. So whenever you're using this medial parapatellar, we have to make sure we leave a millimeter or 2 of the tendon intact. So anterior horn of meniscus is taken off. So as we discussed in the beginning, we do not have a major problem with the MCL since it's a correctable deformity. So my initial exposure for any varus knee would go up to the mid-cornal plane. So as you see out here, it's an external rotation of the leg, mid-cornal release of deep MCL, a spike out here. I go to the posteromedial side, just a soft dissection on this side. You extend the leg. This was the loose body we were talking of.
Yeah. So on the lateral side, you go at the bursa beneath the Gerdy's tubercle, go to the extent of the Gerdy's tubercle, making sure we protect the extensor apparatus. So hold it here. So as you see out here, I do not want any pressures on my skin and those flaps. So this is taken off, but still my incision is from tibial tuberosity at the base to just the superior flange of the finger at the top. There has been a lot of controversy regarding this intrapatellar fat pad. Just a partial resection to improve my posterolateral exposure. That's it, but never make the tendon go bare. So what we have out here is cutting the anterior horn of lateral meniscus also. Now what I have is my ACL in the front and PCL at the back. Rotate this picture. Rotate it clockwise. Clockwise rotate करिए ना. नहीं.
आप थोड़ा पीछे होंगे तो मैं देख पाऊंगा स्क्रीन पे। नहीं होगा तो फिर आप इस साइड आ जाइए कैमरा लेके, आप बॉटम पे वहां आ जाइए, नहीं तो सब उल्ट सब। So I will try to move the camera because he doesn't have a maneuverability part. नहीं, आप यहां से लेके आइए, फुट एंड पे आ जाइए। ठीक है, हाँ ठीक है, थोड़ा जूम इन कर दीजिए। यस, so what you have in the front is the ACL, what you have at the back is the PCL. So I am going to release the ACL out here. Training knees.
Dr. Manoj,
Yeah.
is there any specific test you want to do to see if the PCL is perfectly
Yes, I'm coming here now.
Yeah.
Once you take off the ACL, what you have is the PCL out here. If the PCL is very, very lax, you will be able to translate the tibia in the front and the back. Those are the cases, either you need an ultra congruent insert in a CR or you need to move to a PS knee. This is there in a lot of knees that are subluxating a huge way. So out there in this case, give me an artery. Yeah. So when you see this PCL as a very, very taut and a tight structure, you know that PCL is totally intact. So once you do that, that's in which I mark up my right side. This is very important for my femur. So today we talk of a word called as intelligent knee surgery, where we no more talk of those conventional TKRs alone. We have learned enough out of the accuracy and precision using the navigation and robotics. So basically it is a femoral rotation which is the key. So you mark your transepicondylar axis. Posterior condylar axis is visible. You have your right sides line. So out here, my entry portal is gonna be a millimeter or so, 1 centimeter above the notch of the femur, and 2 to 3 millimeters medial to the midline. So next very important step is what kind of drill you use. I do not use a single portal or single diameter drill. I use a graduated pattern drill in which you have a tip, then you have a wide and then you have super wide part. Because if you put up a normal drill and keep moving, you have a chances of perforating the interior cortex. So move it. So once you do that, you don't require these kind of juggling motions. So in this, we don't have it, but in a couple of cases where you have an anterior convexity of the femur or you have extra articular deformities, those are the cases we go different. So we try to have a capture in the isthmus. Move ahead. So on the top, you have different angles, 3, 5, 7. In this case, a typical knee, I am keeping 5 degrees of a valgus. In cases with a huge valgoid deformity or valgus, are the cases in which I drop these valgus angles, correction angle to 3 degrees. So out here, give me a C-clamp.
Do you routinely do a 5-degree valgus? Is it
again for a recurvatum knee? Your distal cut will drop down from 9 to 7. And for a severe FFD, you will add up 2 millimeters. In this case, what I want is around 9 millimeters. I want to see where it lands.
Okay.
Both on the middle and the lateral side.
Dr. Manoj?
Yeah.
How do you select the valgus angle? Is it routinely that is 5 degree that you use, or?
I have gone through huge deal of variations of those calculations. Now I can simplify. You can very easily go between 5 to 7 degrees for various deformities like these.
Yeah.
And for a valgoid deformity, you can drop on to 3 degrees.
3 degrees, okay.
So we have done all those correction parameters, but this would bail you out in majority of the parameters. So out here, once you have taken this jig off, again, it's a phase where you can go back and cross check how much of distal femur you are cutting. It's very, very important because once you make a wrong cut, there is no coming back. Give me a C-clamp. Protecting your MCL and LCL is the most important part at this stage. For small incisions, especially, you don't want to be fragmenting your extensor apparatus. At the same time, you need to prevent the MCL and the LCL. Again, ये मुझे zoom out view दीजिए, ध्यान को दीजिए. Give a zoom out view. Yeah, zoom out more. Zoom out. Zoom out मतलब दूर ले जाइए. हाँ, पीछे ले जाओ. Okay, so out there at this stage, it's very important. It's just a saw that has to antenna. But once you start working on those emerging technologies like navigation and robotics, you learn how your hand has to move. In the same jig, I can cut rather than 9, I can cut 13 millimeters if I put my hand like this. Or if I put my hand like this while making a saw cut, it will cut around 6 to 7 degrees or a flex femoral cut. So very, very important to control your hand movements. In the beginning, do your cuts, get back on navigation and see what is your correction angle. So the angles in which you use your saw are most important. It's not the emerging technologies or navigation or robotics. It's the principles of doing a TKR.
And Dr. Manoj, using fresh blades also important. Fresh saw blade, new blade.
So we'll take off this one and keep the other pins in. So give me a caliper, Jitu bhai. So you can always move back at every stage. When we are using those PSI, true match customized instrumentation, you see it is 9 millimeters. Show up a close-up view. Yeah. This is 9 millimeters on the medial side. And roughly around 7 millimeters on the lateral side. So at this stage, now comes the most important part. How do you translate this tibia forward? It's simple in this case, but a lot of other cases. Can we decrease the glare? There's a lot of glare out there. Is sterile handle?
That is good, yeah. But you can increase it slightly more. Dark.
So out here, you see this is the PCL. If you do a PS knee, you can always cut it and put a blub like this. But out here, your entry portal is extremely important. Especially, you need to save the neurovascular structures also. So I'll translate around the lateral side, come out the base of the tibia, and translate it forward. Very simply. So if one would, see it clearly, give me a marking pen, sister. This is my whole PCL, which is intact. I do not want to compromise anything on the attachment of the PCL out here. Again, on the lateral side, since I'm using MI incisions, we have special instrumentation which goes on in the meniscotibial ligament on the lateral side and translates it ahead. So you have a full exposure of proximal tibia despite small incisions that you want to carry in MI. This patellofemoral ligament is taken off. Now at this stage, just flex the tibia. I want to take off my entire rim of lateral meniscus, saving the lateral genicular vessel. So if you look at this, this is the entire lateral meniscal rim taken off. Give me a bone cut. So at this stage, we have to do osteophytectomy to trim off the posterior osteophytes. Now, another very important part in this is what is the position of the leg when you're doing a proximal tibial cut? How do you save your PCL? For all beginners who are not used to a CR knee, I would say in the beginning, use this cruciate incision and save across your PCL tibial attachment. Otherwise, I'll teach you how the saw hand has to move on. So out here again, where do you match on your alignment across in this thing? So at the junction of the tibial tubercle, the three parts. In between the middle and the medial half of the tibial tubercle is my proximal point. Zoom out view niche dijiye. No, I need to focus out here. Either. Yes. Along the second ray or the tibialis anterior tendon is my bottom part. So my jig has all possible translations out here. This is where I want to seat it distally. And my proximal mark you see out here has to get onto this. Show me on the proximal part. Let me put up one pen and show you.
Dr. Manoj,
Yeah,
what is the slope you are giving on the?
that's what I'm getting on to.
Yeah.
A very good question, Sanjeev. I'm getting on over there. Actually, the camera guy is giving me problems focusing on the top. He cannot, because of what I wanted to show you was on the top, because slope you don't see from a side. But anyways, give me a C-clamp. So as I see out there, I'm roughly around 5 to 7 millimeters of a slope. Now it's not a formula. This jig has 3 degrees written on the top. So it is an inbuilt 3 degree slope that I have out here. But I want to add up another 3 millimeters to it, for which in each of the I have a possible of translation. Now this is 0. I have brought it on to 8, which would add up another around 2 to 3 degrees. So my composite slope is around 6 degrees. Second thing that I see out here is that's the way I'm going to be hitting on. If I move through this. So if you give excessive posterior slope, what you will have is a subluxing tibia subsequently, a mid-flexion instability and causing a late rupture of PCL. If you cut far less of a slope, what you have is a very tight flexion gap. So you have to go in between the two things right in the beginning. So what I want is 9 to 10 millimeters onto my lateral side. My medial side, I don't even care. I don't want to go to the base of the defect, but I'll cut around, say, 2 millimeters in this portion. I have a composite slope around 6 degrees. The way to see a slope actually is the lateral side view, but I think the camera guy, आप दिखा पाएंगे side से? हाँ, यहाँ से दिखाइए. Because you will see the slope only from the side. ये इतना व्यू साइड से दिखाना है. थोड़ा zoom in करिए. If you look at this angle, this is what I'm trying to tell you.
Dr. Manoj?
Yeah.
Your main idea is to replicate the parent slope of the tibia. That is why you have increased the slope.
Yeah, I want to match to the native slope of this tibia. So these days, slope and varus are very, very important. We no more talk about a pure kinematic alignment or a pure mechanical alignment. We want to move back to a restrictive kinematic alignment. That means I want to leave my tibias in around, say, 2 degrees of varus as they inherently are. Because the moment I convert those acutely varus knees to a total 0 degrees across, they have those pains. So today I would love to leave them in around 2 degrees of varus. So I am making sure that I have this kind of a varus left in as an end point. B, I want to reciprocate the natural posterior slope of this tibia. Now comes the third question. If you are going to use a CR knee, how do you use your saw? You can't just move your saw like this because you will cut the footprints of the PCL at the tibial attachment. So the way to move across is you get onto the side at one angle. You get on out here to the opposite angle. So out here, there are 4 structures to be prevented. My MCL at the medial side, out here. I'm going to prevent the MCL for which I have this retractor. My PCL at the back. My popliteus at the posterolateral corner, because in a small NCN, I can't see the popliteus, but it's very important my guy translates it well. And I have a control over my saw not offshooting the posterolateral cortex, or I'll cut the popliteus. And out here comes the LCL, which is far less chances of cutting it because it's way posterior. These 4 structures are extremely important. In a CR knee, what is very important is I do not damage the footprint of the PCL. Give me this pen. So If you see out here, I'll get back to it. This is the posterior horn of medial meniscus because my MCL is still there, or my medial meniscus is still there. So 2-3 things which are very important to be noted out here. A, look at this footprint. Iska zoom in view dijiye, close up view. Yes, my footprint of PCL is totally intact on the tibia. I have not cut through it. I am onto the slope out here. Give me a measuring gauge. So we intended for a 10 millimeters onto the lateral side. This is 10 millimeter on the lateral side. My intent cut was around 3 to 4 millimeters on the medial side. That's where we are. At each stage, you have to keep checking it. Now at this stage, I will trim off my remaining osteophyte from the back. And at this stage, I will check on my extension gap. Nikal lijiye. So this is my knee totally corrected. No soft tissue correction at all. This is the varus deformity. The point I'm going to teach you is do not keep cutting the soft tissue, the deep MCL, facial MCL, and all those structures on the medial side, pie crusting. It is not required. The moment you correct it through, as you see out here, my initial planning of where my slope has to go, how much of distal femur, how much of proximal tibia, and no soft tissue dissection. I'm absolutely spot on out here. This is one stage I can take off my pins. Ipakadi. It goes off. Now we get on to the sizing of the femur, which is the most important part. Show me this thing.
Sir, I'm Dr. Ankur. I have a question.
Ankur?
So you told that for assessing the PCL as you are doing the CR knee, you saw that what is the laxity or the tautness of the PCL, and if it is not lax, you told that the PCL is intact.
PCL is even if ever we have a cases on this thing, I'll show you even the most grotesque deformities, rheumatoids, FFDs. PCL is always intact. I've never ever seen PCL gone across.
You told
even subluxing knees also.
In one of the assessment point, you told if it is not lax, it is intact. So,
so this is one stage. Give me a hook on artery.
Most common deformity
at this stage. So doc, see at this stage, you have a total control of PCL.
Yes.
Right? You have total control. Now comes the next important part, and that is the rotation of the femur. I just do not believe in posterior condylar axis alone as a marker. So there are 4 markers that you need to keep in mind. A, my rotation has to be parallel to the tibial cut. Most important, Dr. Ranawat's key sign, cut the tibia, proximal tibia, and make the femoral cut parallel to the tibial cut. This is a gap balancing system. B, mark this transepicondylar axis. This is my transepicondylar axis. This is my white sides line. So I have 4 markers now. Perpendicular to the white sides line, parallel to the transepicondylar axis, parallel to the tibial cut, and posterior condylar axis is the last variant. So when I use my sizers, I use it the same way. Give it to me. I'll show you now. So I keep saying in multiple meetings, you do not require any emerging technology to guide you these things. So this is size B. So if you look at this, this is where we were landing up to. My pins are parallel to the transepicondylar axis. They are perpendicular to my white sides line. They are parallel to my tibial cut. Now, when you use your sizer again, what you have to see is mediolateral containment. While I was designing Anthem, I have been speaking a lot on this aspect ratios. That means ML to AP diameters. In Indian patients, we have a problem. We have a problem in the sense that many a times what you require size is the AP is huge, but the ML is very narrow. So what you give across is an overhang which you have to prevent. So anytime I have a cutting jig, I always look at where is my mediolateral containment. Then once you shoot up these pins, finger I'll take you across. So the next step is C-clamp. Am I notching? I do not want to notch. In a CR knee, extremely important, you're always going to have a tight flexion gap. So many times people start undersizing your femur and doing it. This is not right way. Here you have to understand your flexion gap is going to be tight, but you have to match it up with other parameters. You do not want to notch your femurs on the anterior aspect. You do not want to under or oversect your posterior femoral condyles also. So once I am through at this stage is the stage I'll move back to protect my collaterals. Give me screws. Before shooting in the screws, you need to be very, very sure, because translation is only possible up to these stages. You want to upsize, you want to downsize, you want to translate interiorly or not. So in a CR knee, I would always be wanting a higher flexion gap, because that's one of the biggest problems that you have across. So at this stage, the first thing that I want to go through is check my posterior condyle. Now out here on the top, if your section is good, you will have something which is called as a grand piano sign. Cameraman sir, आप यहाँ camera लेके आइए, इधर लेके आइए, आप थोड़ा सा पीछे हो जाइए, मुझे top view दिखाइए, या मैं नीचे कर दूँ. So Sanjeev, what I am trying to show out here is the grand piano sign. Give me a marking pen, ma'am. If you see my top, I am absolutely flush on. I'm not proud, I'm not cutting in. That's my sizing.
So the
I have a grand piano sign, which is this.
Dr. Manoj, the
Yeah.
grand piano sign is also a marker of proper femoral rotation.
Yes.
So if you have a good rotation, then you have a good grand piano sign.
So this is my anterior chamfer. And depending on the design of the femur in this, I have a trochlear recess. So I need to cut off with a small blade. So we'll move back to see this step. Give me the. So at this stage, we'll take off our pins. And we'll see. There is normally in all these varus knees always a posteromedial osteophyte tenting the MCL. So you take this off. So this is what I'm speaking of. If you see this structure, this is my osteophyte tenting the MCL. Very, very important. It's not the soft tissue which is required. It is this release which is required. So I'll take off this osteophyte and show it to you. So this was the osteophyte which was tenting my MCL. Now my MCL is totally relaxed. So as we were talking of, I'll just mark up with a cautery. This is where my femoral attachment of PCL is. We have not touched the PCL so far. Give me a spacer block. So this is my flexion gap. You see this? My extension gap, flexion gap, everything is worked up. Show me this view. So equal flexion extension gaps, no soft tissue releases, only bony corrections so far. Now this is one stage where we'll move back and translate the tibia to size it through. Also at this stage, I would like to go to the posteromedial extent of tibia. I would like to release the meniscotibial ligament out here so that my varus deformity gets corrected. Give me size 2. If you look at this containment, now comes the next question of rotation of tibia. Yes, sir.
Dr. Manoj,
Yeah.
do you use a laminar spreader to see if there are any osteophytes to be removed in the posterior
So
condyle?
that is visible on the X-ray. We will move back in and see that.
Yeah.
Once I size up my tibia, I'll move back in. So this is my tibial rotation with size 2. I'll show you again. The way I flare up, because in all various knees, you have a posteromedial hypertrophy. So I mark my tibias along with the anterolateral corner. This is my anterolateral corner. And then I check my rotation with a rod going up to my second ray, right? इसका long shot पीछे जाइए. You see this? This is where my rotation lies. And at this stage, you can check on to your slope also, whether you have restored the posterior slope of tibia. So any remaining sort of bone osteophyte should be trimmed off at this stage. So because from here on, our tibia is going to be complete, we are going to check on to the posterior osteophytes. Yes, you rightly said, we need to check on those. We use a very thin layer of cement, but we keep those sclerotic areas, certain drill interdigitations for a better cement incorporation. So lift it up, hold it here. Usko uthaiye bas. So at this stage, you have two ways to move through. One structure is this called as an offset osteotome. Offset osteotome would move back to the posterior aspect and take off the osteophytes. The other way across that you want to use is your curved osteotome, typically going to the posterior flare. Now comes the next question. You want to see how you are in the real life scenario. Again, you don't have to flex your components. Look at the medium of cement that you have in the accuracy of your cut should be just a millimeter of cement. Rather, you don't require a cement. It is something like an uncemented that has to move on. Now comes the balancing of the PCL. So if you look at out here, I did not require any release. My pull out, lift off, there is no lift off, there is no pull out. My knee is absolutely balanced in full extension and flexion. Full arc of motion. So, Sandeep, there is no need of cutting the PCL, right? So the message, PCL needs to be saved. So if you look at this parameter, hold it out here. So our soft tissue just goes from the flange of the femur till the tibial tuberosity. There is no soft tissue dissection. While moving back, there was nothing that we erased through. We did not release the MCL physically at all. No soft tissue semitendinosus, semimus release, nothing was done. No superficial MCL release was done. You have a proper sizing of the femur and the tibia, proper rotation, proper flexion, extension, gap balancing. And in this case, nothing was required for PCL. But if at all you feel that you have a tight PCL and this insert is lifting off, your translation is not going clear, because translation means how your insert is positioned as compared to the femur and the tibia. If your insert is lying way anterior, you have a tight PCL. In those cases where you require a release of the PCL, sir, ab aap isko yahan le aaiye, camera ko. I'll show you where it has to be released. यहाँ बिल्कुल सामने से ले आइए. And after this, I'll show you the proper way to do a patellar resurfacing, because many people do not do because of the fear. It's not the resurfacing or not resurfacing, but if you do a patellar resurfacing, you have to do it the right way. So this is where my PCL femoral attachment is. One way of release, one way of release is I'll release these tight fibers out here to increase my flexion gap. That's one way of doing it, which we do most commonly. The other way is you take off the tibia and sort of erase the tibial attachment of PCL. You let it translate naturally. Now, in all those cases who are beginners who feel that despite everything, we want to use a CR knee, but we are lax onto the PCL and we are not very comfortable. That's one situation where you need an anterior lipped insert or an ultra-congruent. Ultra-congruent means that you have a crater like this, the femur would be moving within the tibia in this position. And ultra-congruent would be like that. Anterior lift means that I do not want my femur to translate anteriorly, so I have an extra 2 millimeters of poly out here at the anterior lip. But all those things are constraints. So those are just the sheer backup plans. Otherwise, as a normal, you should use a normal poly, good balancing of PCL, good CR control, and you are off with it. Now comes the next step. How do you do your patellar resurfacing? So the way to move across is you use these kind of patellar forceps. Because remember, our incisions are very small. So reflecting the entire extensor apparatus is never going to be easy. So if you just want to do a chelectomy, you can always move back at this stage. The next stage comes is how much of resection you need to have. Show me bone cutter, man. So at this stage, I will trim off my major osteophytes. My osteophytes are off. Give me a sizer. No. One inside. Huh. I want to see the thickness because it's very important how much of base of the patella I leave behind. So this is something 23. And I want to leave minimum of 12. So my patellar button is around 8 millimeters. So that means in this case, 23 minus 8 would be something I'm leaving something around 15 millimeters at the base. I'll cut 8 millimeters. So this is my jig, which goes on, claws out here. Isko nikal le. Give me a saw. So my resection at this stage, if you read, was 8 millimeters. So a very important part out here is do not make oblique cuts. There's a tendency to make oblique cuts. Show me the caliper. So I intended to cut 8 millimeters. Now see this. This is 8 millimeters. I wanted to keep my remnant as 15. Look at this is 14 millimeters as my remnant. 14 millimeters my remnant, 8 millimeters taken off. Now next comes is the sizing. So if I use, now give me a marking pen. Sizing and positioning are extremely important. We want our patella to be moving into our sulcus. Along with that, we do not want a patella baha or a patella alta. So if I use a 31 sizer, it is too small. I'll move on to 34. And if this is my 34, give me a marking pen. So I'll mark for this where it is seating up. This is my inferior bone. This is my superior bone. Pick up the 3 pegs. 34. Once you put this, then on the lateral side, you're always going to be having some remnant bone which needs to be nibbled off, or you have a subluxing patella. Once you do that, you flip the patella back in space, and this is your patella seating. Go ahead, long shot view. Come on from the side now. There should be no lift off of patella into the button. So the question is, it's not whether I replace the patella or don't replace the patella, but if you believe in replacing the patella, do it the right way. What is the angle of the cut? What is the depth of the cut? How your patella has to seat on? Show me this view. Mixing karo.
Dr. Manoj.
You see this. You see the seating of the
Dr.
patella.
Manoj.
If your patella is lifting off like this, supposing, shoot kariye. If the patella is lifting off this position, that's the way I would go in for a lateral lease after leasing the tourniquet. But in this case, if you see through, look at the arc of motion, how my patella is sitting in. And this is full 150 degrees of bending. Long shot view. Piche le jaiye.
Manoj.
You look at this 150 degrees bending and how your patella has to sit in the sulcus. Very, very important when we design the knees. How you design the trochlear recess coming in like a J curve. Right from the superior to the inferior, your patella movement has to be totally within the notch. And it has to, in a deep flexion knees, You don't want your patellas to be hitting onto the inserts. You want your patellas to be hitting on the notch and superior aspect. So any other point that you would like to ask me, Dr. Sanjeev?
Hello.
Yeah.
Do you see the initial X-ray pre-operatively, whether it's patella baja or alta, and then you decide on the patella button position?
Yeah.
Or you intraoperatively just see it?
See, there is not much amount of a maneuverability you have on, but all our knees are majority patella baha. आप एक बार X-ray दिखाइए वहाँ lateral view, वहाँ दिखाइए. Look at this view again. This is not taken into a proper 30-degree bending, but it is more in the lines of a patella baha. So our patients, our Indian patients, have a habit of going in for deep knee bending. When they go in for deep knee bending, the point to prevent is you don't want your patellas to be rubbing against the inserts. Though all your inserts, give me an insert trial, any trial. Though all my, focus out here. Though all my insert trials do have a notch out here, the shaving of the curve. Close up, iska dikhaiye. You see this defect out here? This is for deep knee bending. So all your inserts, which are meant for a high flexion or deep knee bending knees, will have this cutout into the interior fortune, because you want your patellar tendon and patella to move in. Because in a small statured females, as we have on 5'1", 5'2", 5 feet, there is not much amount of maneuverability of translating the patellas superiorly. If at all I'm having a huge case of a patella baha and I really want to translate, I would have used a 31 mm patella and used it superiorly. Rather than 34, I would have gone in for 31. But in this case, it was not required. My patella seating is absolutely perfect. Show us the range of motion. So if you see this range of motion, your translation, your cruciate is absolutely balanced. Your knee is seating in, patella is absolutely in the shape. And there is not, and I keep repeating, you do not require excessive stripping of soft tissues. What your robotics and navigation teach you is only this thing. Try to prevent excessive stripping of soft tissues. Try to move what is defective. What is defecting in this case was the medial defect. What was defective was the medial and the posteromedial osteophytes. What was defective was the osteophytes on the medial femur tenting the MCL. You take off all those structures off. You do not require excessive releases in this case.
Excuse me, sir. So one question.
Yeah.
Yeah. So what is the threshold you will decide in a CR? You plan to do a CR knee and you change your plan and do a PS knee.
So in the cases where I realize that for balancing my PCL, I have to cut too much of a PCL attachment from the femur. That means 2/3 of my femoral attachment is taken off. So in those cases, I do not want to have a late ruptures of PCL. So the problem is not doing a CR or a PS. The problem is you do not want to have a late rupture of PCL coming in. Because if you have a late rupture of PCL coming in, you will have knees failing in mid flexion. When I come back, I'm going to show you a similar case. That how subluxation happens up and how your knees become unstable. So ultimately, the whole story is that, as you rightly say, if at all you realize that you could not balance your CR knee well, you should always have a PS as a backup with you on the table. Or on the other hand, many companies give you ultra congruent inserts to circumvent those situations. But nothing like a proper balancing. If you see, it doesn't take very long to master this CR knee portfolio.
So many of the surgeons I have seen to test the PCL, they do a inject a normal saline in the PCL. And they say if it gets inflated and the NS is not leaked, the PCL is intact. How you take this idea?
Yeah, question kya? What is the question?
Sir, the question, am I audible, sir? Hello? I think I'm not audible.
So, did somebody ask a question? Sorry, I missed out. I was.
Am I audible, sir?
Yeah.
Yeah, many of the surgeons who do CR knee, I have seen that they inject NS normal saline in the PCL, and if it gets inflated without leakage of the saline, they say that the PCL is intact. How you take this idea? And do you use that?
I have never done it. I never thought that it is required to inject PCL into saline into the PCL across, because PCL has a lot of fibers. You can't inject saline into it. So normally in my systems, I use a lot of cocktails at this stage.
How you calculate that 6 millimeter slope should be required for this patient?
So at this stage, my another carry home message, if you start getting into the revisions, you understand it has the conventional training in the past, there is no need of excessive cement pushing across into the canals. It's basically your fixity and the accuracy of your cuts, which is important. I use hybrid techniques in which I do not shove in cements into the canals. So it's only the proximal area which has an indentation of 1 to 2 millimeters. So if because of infection or any other cause, I have to move back in and use an articulating spacer in these knees. You see, there is no tibias, no excessive cement at the base. So it's purely based on the perfection of your cuts, your proper sizing, so that you land your tibias onto the interior cortex. So in a CR knee, the another beauty that you have is that putting in the inserts is way easier. You can put in your inserts at this stage if you have done your trialing properly. So in this case, I would move in. So I don't need to keep pulling to put on my insert and half of the time fracturing across different areas. Nikal lijiye. So same way as we saw in the tibia, in the femur also, lying and back. Very thin layer, no cement into the posterior femoral condyles. Just a very thin layer of cement going anteriorly. You see out here, a very thin layer. All excessive cement to be taken off. And if you look in from the side, what is the thickness of your cement? Just around a millimeter or so. Because many times we keep talking of the emerging technologies and talking of 0.1 millimeter and 0.5 millimeters, but ultimately you put in 2 millimeters of cement. So where is the question of accuracy? You've shoved up everything with those cements. So at this stage, going in extension, we will push out any excess amount of a cement, as you see out here.
Sir, what is the time you prefer to apply the cement after you mix it?
When it is doing here in my systems, actually by the time I am on the femur cut, my team has already mixed the cement, because for us it's basically the efficiency that matters, but it all depends on how your systems are, what your OT temperatures are, how your anesthetists move in. So normally by the time I'm on the femur cut, my cement mixing already starts. Because I never trial up the inserts, my trialing happens all before. So like in this case, if it is a bilateral, I would have moved on at this stage by the time cement is setting to a second side of the tibia to be started off. So any questions? I know I was translating against the flow, but then again, I'm a stern believer of cruciate tendon knees, and I can tell you that it's not that I've not done. I've done the initial 15,000 of maybe the PS knees and then double the amount of CR knees in the subsequent years. And I seriously believe it's the philosophy you need to believe on. When I was initially getting trained, I was told that CR only for the pristine knees. And by the moment you have a complex knee, FFD, rheumatoids, all those things move on to a PS. Start gaining the confidence, start applying to bigger deformities, you realize that you'll hardly ever require the need of a PS knee. It's not an ego issue. You should always have it on the table. Never compromise it for the patient. If at all it's needed, it's needed. So these patients, after short spinal with the cocktails, can start walking in the next 3 hours. So any other question anybody has? Otherwise, I'll take it up once I'm back into the.
Do you give drains or no drain? Drains or no drains?
No drains. No drains. So I think that's a strong message I would give across to all friends sitting out here. Just try to get across the need of the drains. There's no drain which is required. You do your hemostasis well. Like in this case, we have not ripped across any soft tissues or vessels, but still we'll deflate the tourniquets, check on our geniculars on the lateral side, the medial side, do a hemostasis and get away with it.
Excuse me, sir, one question. While femoral sizing, there are sometimes the size falls between two sizes.
Yeah.
In that juncture, how do you decide for which size to go, higher or lower?
So again, it depends on the implant you're using in. Normally for a CR knee, since we want a higher flexion gap to match up the extension gap, I would undersize. I would use a lower size, but without sort of notching the interior femur. It's a translation of a millimeter or two that has required, because the difference in between sizes is around 2 to 3 millimeters. The jump over between, say, A size to a B size is around 3 millimeters. So if you are in between sizes, that means you're talking of a mismatch of 1 to 2 millimeters. So I would choose the smaller size, increase my flexion gap by a millimeter, ease myself off. And that's what I would use for a CR knee. But for a PS knee, many times you have to use the bigger size.
Do you translate it while going for undersizing to avoid it?
I would translate it posteriorly.
Posteriorly?
Yes.
Then it will...
No, not translate. Sorry, translation will be interior. My flexion gap would be higher. I would increase up my millimeter or so onto the flexion gap.
How much to translate? Any that's eyeballing.
So it again depends on what instrumentation. If you're using, say, Smith & Nephew system, you already have a translation possible of a couple of millimeters within the same system. In these systems, the way I move on is that I keep a millimeter. I would play it with my saw cut only. When I'm using my saw, rather than translating the jig, because a millimeter you can play with your saw only.
Okay. Thank you, sir.
Yeah. Thank you. So thank you so much, guys. And thank you, the team, Sandeep.
Thank you very much. It was an excellent surgery. It's appreciated.
Giving me the platform to be for the first time presenting in Odisha.
Yeah, thank you, sir, very much. It's a beautiful surgery.
Yeah.
I think we can take leave now from the surgery, and then we'll discuss.
I'll see you in the hall out there in the next 10 minutes.
Okay, sir. Okay, thank you, sir. We'll start with our session.
Yeah. Now I invite Dr. Tripathi to give his talk on major dissection versus gap balancing, which is very important in anti-care.
Good afternoon, everyone. So actually, we have already seen all the landmarks. Basically, we have seen the proximal tibia that acts as one of the reference point for the femoral rotation. Second is the postercondylar line, transepicondylar axis, and white side line that we have already seen. And Dr. Manoj Vadhwa has already mentioned that probably Dr. Ranvat prefer to take the tibial surface as the reference point. Whereas many of the literature, they say that transepicondylar axis is the better guide. But what I found in literature is that white side line is probably the best one. And whenever you are doing the TKR for the femoral rotation, only one line should not be the reference point. You should take at least 2 or 3 lines. That is the best one. So what is the goal of TKR? We all know that we need a painless stable joint. And for a surgeon point of view, you need a tibial femoral congruency. Alignment should be perfect, whether you are following the kinematic, restricted kinematic or a mechanical alignment. And what you need is that there should be a perfect balance of the ligaments, capsule, muscle tendon units, and symmetric flexion extension gap. That means in the extension, the medial lateral gap should be perfect. In the flexion also, the medial lateral gap should be perfect. So it has already been proven that if you have a very good alignment, the functional outcome is very good. So balanced and stable knee is our goal. Despite that, 8 to 19% of the patients are not satisfied after TKR, and we all know that. And people are searching for the causes, and they say that probably it is because of the poor balancing of the soft tissues. And second one is malrotations. So what are the problems because of these malrotation in soft tissue? One is that it leads to patellofemoral instability. So there may be patellar, that J curve that sir was demonstrating there. It may not be there, sir. There may be a little bit, that means lateral subluxation there. There may be anterior knee pain, could be because of various causes that we are not going to deal with that. There could be arthroplasty. And the most common and neglected, many of the surgeons, they neglect, that is called as flexion gap instability. And why these patients are not satisfied is that it is a poorly balanced knee. I would say that it is a poorly balanced knee, and that is neglected by the surgeon during the time of surgery. They are happy because even that means ignore about 1 mm or 2 mm, sometimes medial opening is there, but many surgeons, they neglect it. We can accept that on the lateral side, but not on the medial side. And the way of expression of the patients is usually, they cannot express how they feel when there is instability. They say that I feel weakness, I feel recurrent effusion is there. So those are the problems of these two conditions. So what is important is that you need a perfect balancing of the collateral ligaments, and there should be symmetry. So we all know that from 30 to 60 degree of flexions, both the ligaments are quite taut. That is the essential function of both the ligaments on the MCL and LCL to have a proper arc of motions. And the origin of these two ligaments are near the functional femoral axis. So that's how the femoral rotations and your femoral cut affects these two ligaments. So what is the goal is that you need isometric ligaments throughout range of motions. And that's how it came the concept of gap balancing. So when we say that we are doing a gap balancing TKR, we mean to say that our collateral ligaments are properly balanced. There is a symmetry in the flexion extension spaces, and we have restored the mechanical alignment. So if you can achieve all these 3 points, that is a balanced total knee arthroplasty. So this is a major resection technique. So what I mean to say, the major difference between major resection and gap balancing is that the bone cuts reference the bony landmarks. That means we cut the femoral side, the chamfer cuts, anteroposterior cuts, based on few landmarks that we have already seen: wide side lines, transepicondylar axis, and posterocondylar line. Whereas the gap balancing, we take the tensioning of the ligaments, that is the MCL and LCL ligaments, in flexion or in extension. There are 2 types of gap balancing. We all know that either it can be done in the flexion position or it can be done in the extension positions. So coming to major dissection, whatever resected, put back with implants. That is the concept of major resection. So basic principle is that we cut 9 mm of tibia, 9 mm of the femur, and we fill it with 18 mm of that means your component, femoral tibial component and the insert. So here the tibial cut has no relation to the femur cut. So we just cut 9 mm. We take 3 degree of external rotation on the femur side because we believe that. So these are the steps of major dissection basically. So distal femoral cut from the least affected side. Then you cut the posterior cut of the femur based on the bony references. That means transepicondylar axis or wide side line or PCA or posterocondylar line. And then you do the proximal tibial cut. Then you check the flexion extension gap, put the trial implant. If you find little bit asymmetry, then you go for the soft tissue release. So that is how the major dissection technique. So we have resected the bone as per our calculation. The 9 mm will cut from tibia, from the femur, and whatever asymmetry, we are going to release the soft tissue necessarily. So that is called as major dissections. The problem is that we assume 3 degree of varus whenever we say that it is a major dissections. And because of that assumptions, we say that we rotate the femur on the flexion 3 degree of external rotation and to have a proper rectangular shape of your space. And what is the advantage of major dissection is that it is how we are trained, and it provides a reproducible platform for neutral mechanical access, because you can easily do that. You know that now I have to cut 9 mm, I have to put 3 degree, and you all do that. So it is very easy to do a major resection technique. But the 3 degree of varus that we take is not always present in almost all cases. In valgus knee, it may be different. There may be a different angle, particularly in the severe varus knee. So it can lead to flexion gap. And this problem is very accentuated when you flex the knee, and you will find that in a grossly severe varus knee, there is a lateral condylar lift up. So lateral side, you can find the 1 centimeter opening is there, whereas on the medial side, it is grossly contracted. And if you extend it, you will find that everything is perfectly balanced. So that is the problem. If you do this major dissection, you will find that 3 degree external rotation will lead to excessive lateral laxity. So these are the reference points. So I have already mentioned that never take single line for references. And why people feel that this major dissection technique is not good, because they misidentified the landmarks. They couldn't identify. Dr. Manoj Wadhwa has shown us the transepicondylar axis, what is the posterocondylar line. But I will say a very good literature published from one of the very big institute of US, what they found that it leads to erroneous point identification almost more than 50% of the cases. So Alteration of these bony landmarks is also there whenever you are dealing in the distal femoral fractures, particularly in the malunited fractures. Bony deformities, erosions, many patients come with rheumatoid arthritis or some infections where these bony landmarks are actually deformed, or you cannot palpate these there is your points. Then hypoplasia, there could be hypoplasia of the lateral condylar hypoplasia. In those conditions, probably these lines are erroneous. So this is what I was saying. So that if you see the anatomical transepicondylar axis and surgical transepicondylar axis, the surgeon is always trying to rotate it externally. If you see the posterior condylar line, also the same point. So this is how the surgeon tried to accommodate or do that. And they say that actually I'm taking, this is the reference point, and this is what actually they did it intraoperative CT, and they found that that is not exactly the same. So there is a problem in understanding these lines. So white side line is usually consistent, and that's how people say that better to take two or lines. So these are the pros and cons of major resections. It is very good for primary TKA because we all are trained in that. Optimal in case of clearly identifiable anatomical landmarks, large posterior osteophytes, and contract varus or valgus deformities or ligamentous injury. Suppose there is a ligamentous injury, if the ligaments are very much contracted or a fixed deformity, go for a major resection technique. But if you are dealing with a case of where the bony landmarks are altered, it is better to go for a gap balancing. So what are the disadvantages? It can be difficult to identify landmarks. Soft tissue releases are made after trial component placement, and this might introduce difficult to correct laxity and asymmetry. Now coming to the gap balancing, and here actually you need to do the proximal tibial cut and the distal femoral cut has to be done as usual, basically how we do for the major resection. But the flexion gap is tensed to and set to equal the extension gap, and thereby femoral rotation is decided. So for the femoral rotation, actually, we are not doing any soft tissue release. We are correcting the rotations by altering our jig. So we are keeping either 5-degree rotations or 7-degree rotations. So here the tibial and femoral cuts are interlinked because we take the tibial cut surface as our identification mark or the reference point. So this is how the gap balancing, a balanced approach. So in extension, we first do the cut. We balance the extension, the medial and lateral side is matched. And when we flex it, we see that the lateral condylar lift up is there. So we rotate our jig a little bit on the external side. And that's how we balance our flexion gap. So the gap balance technique, distal femoral and proximal tibial cut, remove osteophytes, balance the extension space, perform ligament release if needed. The extension gap is determined. So first we determine the extension gap in this case. And then a tensioner or balancer is applied to tense the MCL and LCL equally on both sides in 90-degree of flexion. And the goal is to equal the collateral ligament tension. So this is how, once the ligaments are equally tensed, then you can choose your femoral size, and then you take the cut size. So this is how some of the cases that I did a few years back with TTK or Bushel Papa, because that was the concept of gap balancing introduction into our market. So this is how we did few of our cases with gap balancing technique. This is a 46-year female rheumatoid knee. So in summary, what are the advantages? These are all the literature that has been published till date about gap balancing versus major dissections. If you see the study, there is a better coronal and sagittal stability in the gap balancing technique in the immediate postoperative period. But the functional outcome, quality of life is that means it is comparable between both the groups. There is no difference between these gap balancing and your major resection technique. The only advantage that major resection technique is having is less altered joint line. Because in gap balancing technique, while there is doing the femoral cut, sometimes you may elevate the joint line. That problem can be avoided by this gap balancing technique. So otherwise, there is no difference between both the techniques.